Welcome to Grand Rounds. Before I do the land acknowledgement and introduce our speaker today, I'm going to announce next week's Grand Rounds, which is at VGH, and it's brought to you by the Division of Infectious Diseases. So I have a question for the audience. What is NTM, that's NTM disease?
Non-tuberculous mycobacterial.
So Sydney, our lead medical resident, knows that answer, and I think you're probably right, because I'm not quite sure. I thought by announcing this that next week's Grand Round will be about whatever that disease is. So if you don't know, please attend. So I'd like to welcome you to Grand Rounds today. The land acknowledgement is to recognize that we're on the unceded lands of the Coast Salish peoples, and we're privileged to be here. Today's presenter is Dr. Hanieh Zargham, who's a dermatologist, and you can see by the title of her talk, she's going to be talking to us about patients who are immune compromised and have skin cancers. Dr. Zargham apparently trained, I'm sorry, I don't know Dr. Zargham, but trained at McGill and is a member of our division. Dr. Zargham.
Thank you so much for the introduction, and good afternoon, everyone. It's really a pleasure to be here today. I'm Hanieh Zargham. I'm a dermatologist, and I, along with my colleague Sheila do skin cancer clinics at St. Paul's Hospital for the kidney transplant patients here. And before I get started, I just wanted to say thank you to the transplant team. It's been truly a privilege to work alongside the transplant team. They are so dedicated and patient-focused, and it's a privilege to serve this population of patients. So the topic of my presentation today is skin cancer in solid organ transplant patients. And I have no relevant disclosures. The objectives of this presentation are to discuss the prevalence of skin cancer in solid organ transplant recipients, to review the pathogenesis of skin cancer in this population, and to discuss the role and function of the dermatology transplant clinic. So we are actually doing more and more solid organ transplantations today than many years ago, and that number is increasing. Solid organ transplant recipients are living longer thanks to the immunosuppression, medications, better surgical outcomes, and post-transplant care. And although this is a wonderful news and a success in terms of transplantation, we are seeing more and more of the long-term consequences of lifelong immunosuppression. And transplant physicians are facing more morbidity associated with transplantation than ever before. One of the biggest consequences is an increased risk of cancer in general in the transplant population. In general, this population is at 3 to 5 times higher risk of cancer than the general population. Skin cancers actually are the most common cancer in transplant recipients and account for almost 40 to 50% of all cancers in this population. And more than 50% of organ transplant recipients will actually develop skin cancer. And when skin cancer does happen in a transplant recipient, the skin cancer is often more aggressive, has higher rates of recurrence and metastasis, and associated with higher mortality. So just to give you an example of how skin cancer is associated with higher mortality than other cancers in the solid organ transplant population, here we're comparing skin cancer mortality, which is roughly 35.27 per 100,000 person years, to that of colon cancer and breast cancer. As you can see, the mortality associated with skin cancer in the transplant population is 10 times roughly that of colon cancer and 3 times that of breast cancer mortality. And the pathogenesis of skin cancer in this population is not all that different from that of skin cancer in the general population, but there are some key differences. So UV light does cause mutations, we all know this, and does reduce local immunity. HPV and other oncoviruses also induce some mutations and can sustain other mutations. And so in a normal functioning immune system, those oncoviruses are often suppressed and the body does remove cells with mutations. However, in patients who have immunosuppression, such as in patients with organ transplants, that immunosuppressive ability of the body is reduced. So the body is no longer able to destroy those mutations as well and suppress the oncoviruses as well. And so many mutations survive and develop into cancers. Now, although all our patients with solid organ transplants are at an increased risk of skin cancer, there are certain key features amongst patients that will place them at an even increased risk of skin cancer. And I've highlighted some of the major risk factors in red, but I'll go over all of them with you. So having fair skin, blue eyes, green eyes, and or generally fair colored hair is a major risk factor. Having a history of extensive outdoor sun exposure and a prior personal or family history of skin cancer also places patients at a higher risk. Male gender also is a risk factor, as is age at transplantation over 50 years. And the other risk factors are longer time since transplantation, of course, and interestingly, the risk of skin cancer is higher in a thoracic transplant, so heart and lung transplants, more so than abdominal transplants. And it's roughly 2 to 3 times higher risk. In terms of the skin cancers we see in the solid organ transplant patients, we can divide these skin cancers into melanomas and non-melanoma skin cancers. Non-melanoma skin cancers include basal cell carcinomas, squamous cell carcinomas, Kaposi sarcoma, and Merkel cell carcinoma. And I'll go over all of these skin cancers briefly in this presentation. So let's start off with melanomas. Melanomas are a type of skin cancer arising from melanocytes, and melanoma accounts for more cancer deaths than all the other skin cancers combined. In this population of organ transplant patients, they have up to 4-fold increase in relative risk as compared to the general population. And when patients do get a melanoma, the melanoma has a worse prognosis compared to the general population, and melanoma-specific mortality is 3-fold higher in the transplant patients. And I just wanted to show a few pictures of melanomas just to emphasize that melanomas do not always look black or brown. Sometimes we do see this red, beefy appearance or even a pink color to the melanomas. Next up, we'll talk about basal cell carcinomas. While basal cell carcinomas are the most common type of cancer, skin cancer in the general population, they are not the most common type of skin cancer in the transplant population. The basal cell carcinomas usually happen on sun-exposed areas, and we like to consider them, or we tell our patients that they're the best type of skin cancer to have. And this is mainly because they're slow growing and they're associated with a low risk of metastasis. However, they can be locally destructive for skin. In patients with solid organ transplants, they usually have a 10 times higher risk of getting basal cells than the general population. Squamous cell carcinomas are the most common type of skin cancer in our solid organ transplant patients, and they're the second most common type of skin cancer in the general population. Now, this number might surprise you. Patients with organ transplants are 65 to 250 times higher risk of getting an SCC than the general population. And when SCCs do happen in this population, they're associated with a poor prognosis. And while the risk of metastasis of an SCC is 0.5 to 5% in the general population, it can be up to 20% risk of metastasis in the transplant population. And squamous cell carcinomas are generally seen in sun-exposed areas. So here I've shown a few examples. However, they can happen in sun-protected areas, and especially in our darker skin patients, they do generally tend to happen on more sun-protected areas. One of the major players in the occurrence of a SCC in the transplant population seems to be the HPV oncovirus, and specifically the beta HPV can be involved in the pathogenesis of this type of skin cancer. Actinic keratoses are really the precursor to, and it can be the precursors to an SCC, as 60% of SCCs arise from pre-existing actinic keratoses. And they can be very subtle, and they can either involute or progress to an SCC. And even though in the general population, the risk of an individual or group of actinic keratoses transforming into an SCC is quite low, this risk is much higher in the transplant population. And also the rate at which it can accelerate or transform into an SCC seems to be much faster. Bowen's disease, or squamous cell carcinoma in situ, is considered a low-grade form of SCC, and it can either occur de novo or from an actinic keratosis, and usually it looks a little bit more defined or scaly and erythematous than actinic keratosis. Now, squamous cell carcinoma in situ is also associated with higher risk of transformation to invasive SCCs in the transplant population. The next type of skin cancer I want to talk to you about in the transplant population is Kaposi sarcoma. It's a tumor of vascular endothelium presenting usually as violaceous papules and plaques, and there is an up to 500-fold increased incidence in the transplant population. The pathogenesis goes back to HHV8 reactivation due to immunosuppression, and the prognosis is relatively good in this patient population as compared to the other skin cancers that we talked about. Merkel cell carcinoma is the last category of skin cancers that I'd like to talk about today, and it's a rare tumor with a poor prognosis and high risk of recurrence, metastasis, and death. It is usually presenting in older individuals. It's usually asymptomatic, rapidly expanding, and happens on sun-exposed areas. There's a 24-fold higher risk and 10-fold increased risk in overall mortality in transplant patients, and the one-year survival rate is 47% in the transplant population versus 89% in the general population. And the Merkel cell virus, polyomavirus, is involved in the pathogenesis of Merkel cell carcinoma, and the reactivation of this virus due to immunosuppression along with sun exposure seems to be the cause of this cancer. And here are a few pictures of Merkel cell carcinoma. So by this point in the presentation, I hope I've been able to convince you that skin cancers are a big problem in the transplant population. They are more common, more aggressive, associated with more metastasis, and associated with more morbidity and mortality. And so what this tells us is that the transplant population needs comprehensive and proactive skin care. Now, this comprehensive proactive dermatology care for our transplant patients is comprised of multiple components. Part of this plan is to provide patients with complete skin exams to detect and treat any skin cancer or precancerous lesions. The other component is to control risk factors where we can. And the last component for our patients who are still getting very aggressive skin cancers is to implement chemoprevention, which I'll talk about in the following slides. So let's start with the full body skin examinations. Patients with organ transplants do need very regular skin examinations. And this is really to stay ahead of the skin cancers and to diagnose precancerous and early cancerous lesions. The first visit should ideally be before the transplant or in the first 6 months after a transplant. Patients with no skin cancer history should ideally be referred every 1 to 2 years for a skin check, and those with an actinic keratosis or one low-risk skin cancer, such as a basal cell carcinoma, should be seen every 6 months. And those who have had a high risk or multiple skin cancers should ideally be seen every 3 to 4 months. And it's really important to mention that we do palpation of lymph nodes in all patients with a history of skin cancer, and genital exam is also recommended in all patients given risk of HPV-associated skin cancers in the genital area. And what's really interesting is that there have been few articles recently published that really emphasize this point. And it seems to be even more important to do genital exams for our male patients, as female patients routinely do get gynecological exams, so that area is assessed. Self-skin examination is something that I talk about with all my patients during their appointments with me. And I really emphasize that they should be doing monthly self-skin examinations. And high-risk patients are also educated on self-examination of lymph nodes. There are multiple online tutorials about how to do self-skin examinations. And I also review what to look for on their self-skin exams. And I do really think that providing patients with this information is really empowering, can lead to earlier diagnoses of skin cancers. So one question that you might have is post-transplantation dermatology surveillance, is it worth it? And there was a recent Canadian population-based study that tried to address this question. And their finding was that adherence to annual post-transplant skin exams for at least 75% of the follow-up time was associated with a 34% reduction in the rate of advanced non-melanoma skin cancer. So that is quite significant. Now, we talked about skin checks and also about controlling risk factors where we can. And the major risk factor which we can control is UV sun protection. And that really starts with educating our patients, even when they're on the waiting list, about their increased risk of skin cancer. It's really important to be familiar with the different methods of sun protection, and we go over this very carefully with our patients at every visit. So how to be sensible, a little play on words, but sunscreen. I tell my patients that sunscreen is necessary, but it's not enough. The protection that's claimed by sunscreen comes with an amount and frequency that's far superior to what is being used by the average individual. And sunscreen does not protect us completely. So what is really important in addition to sunscreen is wearing sun protective clothing. I tell my patients that they should actually get 3 hats, one to leave in their car, one at the front door, and one in their bag, so that they're always going to be accompanied with a hat. And of course, seeking shade when it's very sunny outside, and wearing glasses are also good ways to implement sun protection. Now, studies do show that most of our patients, our transplant patients, are actually aware of their increased risk of skin cancer and the role of the sun. However, half of transplant patients don't practice sun protection behaviors at all, or do so very incompletely. So there's clearly a discrepancy between knowledge and behavior. And there may be multiple factors that are responsible for this. Perhaps our patients are not taking skin cancer as seriously as other cancers. There seems to be a negative personal attitude towards sun protection, and some people see it as time-consuming to put on sunscreen and sun protective clothing, and sometimes they can be really uncomfortable and unpleasant, or not fashionable. And the cost of sunscreen is another inhibiting factor that is responsible for this discrepancy between knowledge and behavior. So the good news is that studies have shown that repetitive sun protection education, as well as receiving the education in the context of transplant dermatology clinics, seems to be more effective. And transplant patients who've had annual skin checks were actually more likely to practice sun protection than those who did not. So during our clinics, we provide sun protection education, and oftentimes it is repetitive, especially for patients who have been seeing us for many years. But we try to emphasize the key points at every visit. And also we give our patients a bag of free sunscreen so that they're motivated to try different types of sunscreen and find one that they're more likely to use. Does sun protection actually work? Now, transplant patients who use sunscreen regularly do have a decreased incidence of skin cancer. So it seems that sun protection does work, and even later on in life. And there was an interesting study that I wanted to share with you. There were 120 matched transplant patients divided in two groups. Both had sun protection education, but one group also received free sunscreen. Interestingly, the sunscreen group developed less skin cancers in 2 years during the study. Now, what's really important to note is that both groups did have decreased vitamin D levels, especially the group that was using sunscreen more consistently. And this highlights the point that transplant patients who practice sun protection do have high risk of vitamin D deficiency. As a consequence, we should be monitoring vitamin D levels regularly in this patient population. So we talked about skin checks, the importance of sun protection, and the other risk factor that perhaps in the future we'll be able to better control are oncoviruses. The HPV oncovirus is a major oncovirus that plays a role in the pathogenesis of skin cancer in the transplant population. Beta HPV is actually detectable in over 80% of squamous cell carcinomas in this population. And although the Gardasil 9 vaccine is protective against the 9 alpha HPV subtypes, it is possible that production of cross-protective immunoglobulins occurs, and there may be some protection for the beta HPV as well. And there have been some anecdotal reports of a positive role of vaccination in preventing skin cancer in immunocompetent patients. And while the studies the findings are still inconclusive due to small sample sizes and long latency of SCCs, it may be helpful, especially if future studies demonstrate a positive effect with vaccination. And so many researchers and transplant clinics across North America are now recommending vaccination with Gardasil vaccine prior to organ transplantation. The other risk factor that sometimes we can control is immunosuppression. The higher the level of immunosuppression, the higher the risk of skin cancer. And so patients who've had multiple skin cancers or really high risk skin cancers, they may actually benefit from immunosuppression modification. And of course, this is done in conjunction with the transplant team, and there are multiple ways to do it, and the transplant team can choose which way is best for that specific patient. The last thing I wanted to talk about in terms of patients with high-risk skin cancers is chemoprevention. So chemoprevention with systemic retinoids has been implemented in many clinics across North America. It's effective in reducing the rate and numbers of SCC formation, and it may delay the recurrence of high-risk or metastatic skin cancer. Patients with a high tumor burden or who are high risk of metastasis may benefit from chemoprevention with systemic retinoids. However, patients who are started on systemic retinoids have to be maintained on systemic retinoids. And if discontinued, there can actually be a rebound effect that's very difficult to control. The other setback with systemic retinoids, and the reason that we are not widely prescribing them for most of our patients, is that they're associated with a lot of side effects, cheilitis, alopecia, xerosis, and pruritus in up to 75% of patients. There are also systemic side effects to worry about, such as hyperlipidemia, increased LFTs, and increased fasting blood sugar. And so because of that, there are major limitations to actually prescribing systemic retinoids, although they can have a lot of positive impact on our patients. The other up-and-coming medication, or I guess in this case, supplement in terms of chemoprevention is nicotinamide. It is a type of vitamin B3 that enhances DNA repair following UV radiation. It can block UV-associated immunosuppression and be an anti-tumor agent. What's great about nicotinamide is that it's really well tolerated and there are very minimal side effects. So as opposed to other forms of vitamin B3, it's not associated with flushing or hepatotoxicity. Now, the benefits of nicotinamide were really demonstrated in this phase 3 randomized trial of nicotinamide for skin cancer chemoprevention. I want to highlight that this study was done in immunocompetent patients, but it did show a 23% decrease in the rate of new BCC and SCC diagnoses in the nicotinamide group compared to the control, and a 13% decrease in the rates of actinic keratoses just 12 months after treatment. There have been studies that have looked at the role of nicotinamide in chemoprevention in transplant patients. However, these studies have largely been inconclusive. There have been some that have shown a positive effect and some that have shown no statistically significant reduction in skin cancers in this population. However, there is currently a national study being done on this topic, and hopefully the results will be published and will guide better selection of which patients would benefit from chemoprevention with nicotinamide. So it may be a very promising alternative to retinoids as it is non-toxic and associated with very little side effects. But again, the jury is still out and more studies are needed. So we're nearing the end of the presentation, and before I conclude, I just wanted to show this picture as an illustrative case. This is a patient who I recently diagnosed with Kaposi sarcoma. He is a transplant patient, and this photo I hope can illustrate three things. The first thing is that all patients with organ transplants are at an increased risk of skin cancer. The second is that the findings of skin cancer in this patient population can sometimes be very subtle, and the threshold to biopsy should be quite low in this population. And the third point is the importance of a multidisciplinary approach when helping these patients. The importance of having a dermatology clinic that's very closely associated with the transplant team. And fortunately for this patient, we were able to help him and quickly get the investigations that were needed for the management of his Kaposi sarcoma. So in conclusion, the take-home messages here are that fortunately, transplant patients are living longer, but they are also at higher risk of cancers, specifically skin cancers. Skin cancer has higher morbidity and mortality in this population, but fortunately, the skin is also the most accessible and visible organ. And so regular skin checks, along with controlling risk factors where we can really help in detecting and treating skin cancers early in this population. And the other important point here is not to forget vitamin D monitoring in these patients, especially if they're being compliant with good sun protection. And lastly, nicotinamide and HPV vaccine are perhaps our future hopes for better management of these patients. But again, more studies are needed on these two topics. So thank you so much for your attention. And if you have any questions, I'd be happy to answer them. All right.
There's, I think, a Zoom question.
There's a Zoom question?
I think so. Our Monday Seychelles.
Oh, Dr. Monday, did you
Hi
have a
there,
question?
Barry.
Hello.
It's good to great rounds. Thank you. I'm particularly interested in Solarase, which is a diclofenac in hyaluronic acid, which is available in every other country for treatment of the solar-induced lesions. And I think David McLean and Jason Rivers did an interesting paper about 20 years on its use. And it is being used in some countries for the transplant group. Any comments?
Yes, diclofenac can be beneficial in the treatment of actinic keratoses. compared to some of our other treatment options, it's not our first treatment option. So this diclofenac would be something I would consider for a patient who cannot do the other treatment options, such as 5-fluorouracil or photodynamic therapy or cryotherapy. It is a good treatment because it's associated with very little side effects, and it's not as irritating as some of the other treatments. However, in terms of efficacy, there have been more documented treatments such as 5-fluorouracil that we prefer for our patients in the transplant population currently.
And of course, we don't have it as a proprietary brand in Canada.
No, yeah, it would have to be compounded. So the few times that that patients have specifically, and it's usually been patients that have specifically asked for this, it would have to be compounded or just diclofenac on its own.
Thank you.
My pleasure. Great question.
Any other questions from the group? Alex.
In Australia, there was the scandal about how much SPF was actually in many of the sunscreen products from many different companies.
Yeah.
Is that localized to just Australia, or could that be in Canada as well?
Yeah, that's an excellent question. It was very surprising. Oh yeah, the question was that in Australia there was recently a big scandal about how much sunscreen is actually on some of the marketed sunscreens. Specifically, a few of the brands, it was shown that they contained very little SPF. Some were as low as 15 or 10, despite claiming they were SPF 40 or 30. And so that's a great question. So what we advise our patients is to look at the Canadian Dermatology Association's recommendations for which sunscreens they are suggesting. And those are sunscreens that have been looked at by the Dermatology Association and have really been given that seal of approval. So to the best of our knowledge, those sunscreens do have the marketed SPF that's claimed.
Any other questions? If not, I have a question. Are there any studies that look at populations that receive transplant that actually are culturally protected from the sun?
So that's a great question. Culturally protected, so that practice more sun protection.
They were hijab. They're covered.
Yeah. So yeah, no, I did not come across any studies particularly on that topic, but one interesting study was on the topic of Asian patients who receive a transplant. And it seems that Asian patients who come from the equatorial regions of the world are more at risk of squamous cell carcinomas than Asian patients who come from other parts of that are not so close to the equator. So I'm sure cultural practices of sun protection do play a protective role, but that's a great topic of an article that should look at that. Yeah.
Okay. Any other comments or questions? If not, oh yes.
So as the transplant patient population grows exponentially, we obviously have differential care and access to dermatology for assessments, and we rely a lot on primary care physicians to be doing regular skin exams, which on the transplant physician side, I can't confidently say actually happens on a regular basis. So which patient population do you think needs to see dermatology specifically versus patients that are safer or reasonable to follow up just with their primary care physician?
So that's a great question. In the ideal world, every patient who got a transplant, regardless of whether it was at St. Paul's or VGH or in Surrey, would get a skin check, regardless of the type of transplant that they got. However, there are some limitations, of course, and unfortunately, dermatology is not a specialty that is, where we have access to a lot of dermatologists in this province. So there have been some tools that have been developed to stratify patients based on their risks and to see which patients need more frequent follow-up or closer follow-up. Now, these articles haven't said those patients that are low risk relatively can just follow up with their GPs, but in a resource, in a low resource setting, we can kind of apply those stratifications in terms of seeing which patients really need to come see a dermatologist and be referred to a dermatologist. The major risk factors, and again, in that particular study, every risk factor was given a point, and so you would calculate the number of points that each patient had, and that would stratify them in terms of their risk. The major risk factors were male sex, age over the 50, white patient, so Caucasian background and whiter skin type, and a thoracic transplant as opposed to an abdominal transplant. So even though less thoracic transplants that are done than abdominal transplants, those patients are slightly at higher risk. And those 5 characteristics would be what would guide patient referrals in a very low resource setting. But hopefully we can establish more clinics like the ones here at St. Paul's Hospital, and hopefully we can provide better care for our patients, because it's a lot to ask of our family doctors in the community, and it's a big responsibility as well to be performing skin checks on all these patients. And as you saw in that picture that I showed at the end of the presentation, sometimes the findings in these patients can also be very subtle, and it just takes a very low threshold to biopsy, and that might be something that might be difficult for family physicians to do in the community as well. Go ahead.
I guess related to that, what's the state of the art on like machine learning or an AI that they could go for almost a pan skin scan, almost like at the airport, if you can throw your hands up and they can do a 360? Is there, I know radiology and pathology, there's questions around the visual documentation, and they can iteratively figure out which ones were high hit or not, but is there any?
Not in BC at the moment. So in some bigger centers in the US, there are some imaging tools such as the Intellis, is called the Intellis Studio by Canfield, where patients go in, it takes a couple of minutes, and all their moles are scanned basically, and photos are taken. However, those pictures still need to be reviewed by dermatologists. And the other point there is that those systems usually detect changes in moles better than, let's say, diagnosing a skin cancer on a first scan. And the reason for that is that AI still has a long way to develop before we can trust it to scan a mole and tell us if a biopsy is required. But definitely there are systems that are developing, and AI is being integrated in a lot of these systems, and hopefully we'll be able to use these tools when they're more widely available and reliable.
So to follow, how long does it take for a person, first of all, to see a dermatologist with this? And secondly, once they're seen, how long does it take you to go over their skin examination? What are we talking about?
So specifically for the transplant, okay. So we actually have an amazing transplant team here at St. Paul's Hospital. So a lot of my clinics, I actually see new patients who've just had a transplant within the past year. So I think that, and Dr. Al can also speak about her experience, but fortunately we're at St. Paul's Hospital, it seems that we really do have a good ability to offer our services to the patients that need them. But I'm not sure what the situation is like for patients who are receiving their transplants elsewhere.
And how long does it take you to go over thorough skin examination?
So I'm quite, and Dr. Oz the same way. We're quite thorough and detailed. So it does take usually 10 to 15 minutes to have that visit, and we also do some counseling during the appointments as well to go over. What the patients should be looking for on their own self-skin exams, and when to come back to see us if anything is changing.
Yeah, Hanieh, thank you so much. That was just excellent. I took notes. I have, references, so I really appreciate that. And I think for the transplant clinic at St. Paul's, it's been wonderful to have you there because it's been there for about 15 years, and Hanieh is the first, second colleague who's come on as a transplant dermatologist. There are no other transplant dermatology clinics in the province, and so it's really for other transplant groups or nephrology groups who are seeing transplant patients, it's really about creating relationships with community physicians. We're in a really lucky position because our mandate is if you've had a transplant at St. Paul's, primarily a renal transplant, but we will also see, of course, our transplant patients that if there's worry about a skin lesion, we'll get you in at the next clinic. And the clinics run about once a week. And so that's the service that we want to provide for our patients who have lesions that come up in between their follow-ups. And the things that people will write us about are, scabs that don't heal, lumps that are doubling in size, bleeding lesions, things like that. Those are the things to ask our patients. And then with regard to the community, it's completely different. And that's when there's an app actually called the SunTrack app, SUNTRAC. It essentially takes every single risk factor, 5 risk factors, all the ones that Dr. Zargham mentioned, as well as a previous history of skin cancer, which is a huge risk factor. And it sort of tells you when you should start screening the patient. And so for an Asian woman who's less than 50, who's had a renal transplant, has never had skin cancer, the first screen, as recommended by this validated app, which was created in the States, will be at 10 years post-transplant. And so in the community, that might help to differentiate the fair-skinned male who's 60 years old, who's had a previous BCC or SCC, and has a very high risk of probably 5-year risk of skin cancer being up to 40%. So there are some, so SunTrack is helpful, a helpful app that can be used by, it's just so easy to plug in the features, but after a while you kind of memorize the patients who need to be seen and not seen. So in the community, I know that they would not be able to absorb every single transplant patient, especially the really low risk patients, for just a normal everyday skin examination. Even in the perfect world, every patient would be examined regularly because the counseling is so important. So I think at least I think every transplant patient, just as Dr. Zargham said, should have that counseling on a regular basis and skin cancer screening starting early by either their family physician if they're low risk. But if they're very high risk and have a lot of spots, papillomas, freckles, moles, it can be really challenging. And so those patients will be better served probably by skin dermatologists. So I think that's the way to kind of triage the cases that we see. But our clinic, if anybody calls and there's a skin lesion of concern, and sometimes we get photos, but they're often not necessarily helpful, then we're happy to see patients. And occasionally we'll do consultations from the province for people who are very complex, hundreds of skin cancers, or one egregious invasive skin cell carcinoma with there may be complications or metastatic, high metastatic potential. And then we can do consults on those patients, but they still need to be seen by another team in their home environment.
Do you have any response from the transplant community in terms of, since this is the only place we hear that this is being done?
I mean, I think we're, just to echo what Sheila mentioned, that we're really lucky to have our dermatology colleagues see patients with liver. I know that not everybody has that luxury, and a lot of our community transplant patients do not see dermatologists and are not properly screened, as you mentioned, because of the lack of access to dermatology support. So and our population is growing exponentially. Like the number of patients living with a kidney transplant in BC, the number of patients living with chronic kidney disease in BC, the vast majority of them now are transplant patients. And so we're going to see more and more skin cancers. And so I think expanding what we have here at St. Paul's to other centers is going to be the way of the future. But obviously that depends on funding models and interests and whatnot. So hopefully we see more of it.
No other comments or questions? Yes, sorry. Oh, sorry.
He's gonna.
Ron, do you have another question?
Just a comment in that there's a number of family physicians, me not being one, who've done diploma in dermatology either from Wales or Australia. And should it be possible to train them as community resources to do screening for those that aren't able to get in?
Yeah, I think that the more awareness there is about skin cancer and the more family physicians are trained in dermatology and doing skin checks, the more we're going to catch skin cancers at an earlier stage and be able to better counsel these patients on what to look for and how to protect themselves from the risk factors that increase their risk of skin cancer.
Thank you very much.